Guys, before we start, we do record and we're live, but I just want to greet everyone first ahead of time because I want to make an announcement, make sure everyone knows about the water. There was a main break in Skokie, so the water is not clean, safe to drink, and it is recommended. So we have bottles of water if you want any. We're making coffee with bottled water. And if you should wash your hands with soap, I'm told, but then use the hand sanitizer afterwards. That's the proper full technique. So I want to make sure everyone here knows that. I think that's it for our off the recording. But we're going to get started in pretty much right now. I'm going to grab my. So Phil, we're not live now, are we? Oh, we are? Okay then, we're live. Didn't know. Well, welcome, good morning. Thanks for coming out this morning. If you're viewing us on the internet, on our stream, welcome to you as well. We are here in Skokie, Illinois, the Ethical Humanist Society of Chicago. I am a longtime member and part of our moderating core. We rotate who talks, who presents, and today we have a speaker from who's a local person and is a family physician, which I am also a family physician, but our speaker, Dr. Sidney Doe, and I have not met before. Today was the first time, but we are both members of Physicians for a National Health Program, and that's how we arranged today's speaker, which will be on that subject. We'll more about that in a moment. Thanks for coming. It's a snowy day, but hopefully we'll have some ideas to warm us up here. I want to say something else about the Ethical Humanist Society before we get rolling. I am going to tell you a little bit about the values that we see as important here. We value the importance of living an ethical, responsible, and joyful life. We promote intellectual, philosophical, and artistic freedom, avoiding dogma and rigid creed. We nurture a sense of wonder about life, nature, and the universe, and are inspired by positive models of human achievement shaped by the forces of humanism, democracy, science, and religious reform. We cherish human diversity, and we focus on what we have in common, not what keeps us apart. So welcome. And today, speaker, we have a whole series of talks. We talk about politics and arts and science. Today's talk really is about healthcare. It certainly bleeds into politics and probably economics as well. And today's speaker is Dr. Sidney Doe. The title is From Coverage to Care, America's Insurance History and the Case for Single Payer. Dr. Doe is faculty at RUSH-Esperanza Family Medicine Residency in Chicago and an assistant professor in the Department of Family and Preventive Medicine at Rush University. She serves as chapter director of the Illinois chapter for Physicians for a National Health Program and as a new physician member on the board of the Illinois Academy of Family Physicians. Her professional interests include health policy, women's health, and HIV medicine. PNHP, Physicians for a National Health Program, is a single-issue organization advocating for universal, comprehensive, single-payer national health program with over 25,000 members and chapters across the United States. PNHP is at the forefront of this movement. PNHP is an organization that was started here in Chicago many decades ago. And today, in this presentation, Dr. Doe will explore the complexities of the U.S. healthcare system, tracing its evolution, comparing it to systems in other countries, examining key components such as Medicare Advantage, Medigap plans, Affordable Care Act, otherwise known as Obamacare. She'll also discuss potential future directions for healthcare reform to address current challenges and improve outcomes. So please help me welcome Dr. Doe.
I Hi, thank you so much for the introduction. So like Rick mentioned, my talk is titled From Coverage to Care, America's Insurance History and the Case for Single Payer. But I have an alternate title today because what Rick asked for was some description of the healthcare system mess that we're in, and I feel like that's very apt for what we're about to talk about. So like Rick mentioned, I'm a family medicine physician practicing in Chicago, and I'm one of the co-chairs for the Illinois chapter for Physicians for a National Health Program. I'm not a health economist, and so it's likely you all will have questions that I will be unable to answer. But if you're interested in more learning on this topic, I'd like to steer you to the friendly faces on the board. These are some of my favorite thinkers and writers on this issue, and I also put 2 of my favorite books on the topic up on the board. But my role is mostly as a family physician who cares a lot about the system that I'm working in, and when I have the opportunity, I like to advocate to try to make changes in the system. All right, so part 1 of my 2-part talk is going to be how did we get here, a little brief summary of the history that led us to this point. So hospitals in the United States started in like the 1700s, but healthcare didn't really exist like how we have healthcare today. There weren't really medicines for a lot of diseases. So healthcare was very like a la Little Women, like, oh, Beth is sick, so we'll take her to the sea and she'll like breathe in the sea air and we'll like feed her soup and we'll pray over her. And so most people's families were able to do that for them. When people didn't have families to do that for them, hospitals filled the gap. Hospitals were predominantly in cities because that's where people were largely without their families. And hospitals were funded largely by charity and philanthropy. They were not funded by taxpayers, and patients, for the most part, didn't have to pay anything. And then in 1797, the United States had its first example of risk pooling, and it was the brainchild of everybody's favorite founding father, Alexander Hamilton. And the issue was that fishermen were docking in these cities, and they were disproportionately sick, and they were disproportionately far away from their families. And so they put a lot of strain on local charity groups. And so Alexander Hamilton spearheaded this federal policy where ship owners would have to pay 20 cents per month spent at sea per sailor upon docking to a customs agent, and if they didn't pay that, there was a $100 fee, and that money went directly to the local charities to help cover the hospital costs for caring for these sailors. And those of you who have read about health policy might recognize this as similar to like the individual mandate in philosophy, that it's obligatory to pay for the coverage. And in one of my favorite books on the topic that I mentioned, We've Got You Covered, they make the argument that this is an example of policymakers deciding that they're going to prioritize upfront caring for people without resources who need care in this country, and we've seen that throughout American history, that that's something we prioritize. In this talk, I'm not going to make like a philosophical argument that we should care about like poor people or sick people, but the argument that these authors make is that we already do care about those things inherently. Like as human beings, we have like an altruistic instinct, but it's better for everybody involved if we formalize that commitment to take care of those people and pay for it up front, as opposed to waiting until things become emergencies or only caring about them when they have extremely sympathetic stories. And this is an example of policymakers recognizing that as early as the 1790s. So private insurance started in the United States at Baylor University Hospital. It was a program that was offered to local teachers where they could pay like 50 cents a month, which is $7 in today's money, in exchange for having 21 free hospital days covered for them should they need them. And other local hospitals joined in on the plan, and that was how Blue Cross got its start. And then it took physicians a while to accept the idea of third-party payers, but eventually, about 10 years later in California, Blue Shield took hold, and physicians liked it initially because it was easier to bill private insurance companies as opposed to like sick patients. It was more assurance that they would actually get the payment for the services rendered. But I want to make a point that health insurance was always easier and always intended in this country to be done through employers, because it's a natural instance of risk pooling. And by that I mean that insurance companies could calculate what they estimate the cost of taking care of a population of employees would be, and then divide that among the employees and add a profit, and that was the premium. It's always been more difficult and just less intuitive how to make private insurance work for individual people, because the individuals who are more likely to seek insurance are individuals who are more likely to be sick, and that's a riskier proposition for insurance companies. So from its very start, private insurance in this country has been focused on employers and populations of employees. And then employee-sponsored health insurance really took off with World War II for a couple of reasons. One reason is that because there was increased labor demand with World War II, all the people going off to war and like increasing production, the federal government instituted an anti-inflationary cap on wages, and to continue to compete for workers, employers then just offered juicier benefits packages. Another reason was that unions were really powerful during this period in American history, and the unions were able to negotiate for stronger benefits. Additionally, in 1954, there was federal legislation that excluded benefits from taxes, and so it became in everybody's best interest, both employees and employers, to receive. Yes, of course.
The back row said maybe you could speak into the microphone a little bit.
Of course, yeah.
I'll turn it up.
Okay.
We'll turn the volume.
Okay.
Let us know.
Yeah. Is this better? Yes. Okay, sorry.
Thank you.
Yeah, of course. You think we're good? Okay. Yeah, so benefits packages were excluded from taxes, and so it became in everybody's best interest that employees receive more of their compensation through benefits as opposed to wages. So those are reasons why it expanded very quickly. And you can see like by like the 1970s, 1980s, like 80% of people in the United States were getting their insurance through employer-sponsored insurance. But I want to emphasize by sharing this history that this was an accident of history. This happened because of like a series of unfortunate events. This was never like intentional or like thoughtfully designed. This happened because insurance companies were pursuing profit motive, and there were policies with other aims in mind that led to this happening. So this is how we got here. And as insurance became more and more associated with your employer, and as healthcare advances continued, and suddenly access to healthcare was the difference between a life of misery or possible death and an extended and happier life. It became more and more important that people have access to healthcare, and it begged the question of how we're going to cover people who were not able to get health insurance through their employers, especially people who are like very sympathetic, like low-income children and the elderly, and people with really with debilitating diseases, especially ones that were like really heart-wrenching. So it became politically important to offer something to help cover those people. Because like I mentioned before, we do have an instinct to want to help people when we know that, when we feel like they're deserving of help. And so it was, there was a lot of momentum behind trying to expand insurance coverage as healthcare got better. So we instituted a series of Band-Aid solutions. So on the top left, that's Lyndon Johnson in 1965 signing in Medicare and Medicaid. And Medicare, as I'm sure many of you know, is to cover health care for people over 65. You're automatically enrolled. So 3 months before your 65th birthday, people get a package in the mail that explains their benefits. Then in 2006, we implemented Medicare Part D to cover pharmaceuticals, but you have to reach out to enroll in that. And Medicaid at the same time, the goal initially was to cover for low-income people, but eligibility was tied to whether or not you belong to certain, especially sympathetic groups, like if you're a pregnant woman, or if you're a child, or if you have more children, it's easier to get enrolled. And then the bottom left is the God Committee, which became really well known in like 1962. There was a bunch of press about it. The problem was that dialysis was a new technology that was available at a hospital in Seattle. For those of you who don't know, dialysis is a treatment for people with end-stage kidney disease, where people are hooked up to a machine for hours, and the machine slowly takes their blood out little by little and cleans it the way that your kidneys do, and regulates the amount of electrolytes in your blood the way your kidneys do, and puts the blood back in you. And it takes a long time, and it's very expensive, especially when it was a new technology. And the hospital could not afford to provide this service to everybody who qualified for it. And so the hospital set up this God Committee, as it was later called by the press. That was not the initial name. And this committee's job was to decide who would get the dialysis treatment and who would not get the dialysis treatment. And it was made up of community leaders and like regular citizens. But when it came out that this is how this decision was being made, there was a lot of public outcry. And famously, advocates for patients on dialysis went to the extent of rolling a patient in on dialysis to a congressional hearing to receive dialysis in front of policymakers. And as a result of all of those efforts, Medicare was expanded to people of all ages who were on dialysis. But remarkably, coverage is not extended to people of all ages for the treatment that would actually prevent end-stage kidney disease in the first place, which would be cheaper and obviously like safer and better for the patient, like primary care or diabetes medicines or hypertension medicines. And additionally, coverage is not extended to people who need post-transplant medicine. So dialysis normally, at least in this day and age, the idea is you're on dialysis until you're able to get a kidney transplant. After getting a kidney transplant, people need to be on expensive medicines for a long time for the rest of their life, and those medicines are not covered. So we end up with this awkward patch over this system that covers some people when they have one stage of this disease, but nothing for prevention and nothing for later stages, and it's an imperfect solution to the problem. Similarly, we have other patches to cover other diseases when they were like especially sympathetic or in the public eye or when they had really good advocacy. Tuberculosis is one of those, breast cancer and cervical cancer, but only if you're receiving care at certain clinics. COVID, but none of the long-term effects of COVID. And for people who went to the emergency room during the peak of the pandemic who thought maybe they did have COVID, but maybe they had something else like a heart attack or a pulmonary embolism or a flu, their care was not covered. And on the top right, I have a picture of Ryan White, who was a teenager who famously died of AIDS after getting it from a tainted blood transfusion. And his family did a lot of really admirable, fantastic advocacy to get HIV and AIDS medicines covered by the federal government. But again, these are all Band-Aid solutions for specific diseases. And on the bottom right, I have Katie Beckett. So Katie Beckett was a little girl in the 80s who, when she was 4 months old, contracted viral encephalitis that left her with disabilities the rest of her life. And her family, in a story that's very familiar for people who work with or know people who have disabled children, they maxed out their private insurance benefits at $1 million, and then they had to transition to Medicaid. Medicaid had restrictions at the time that for long-term disability care, you have to live in a long-term care facility. You can't live at home because it was deemed more cost-effective at that time. They felt it was more cost-effective. So Katie Beckett's family did a lot of, again, really admirable advocacy to try to change that rule and create an exception for chronically sick children. And Ronald Reagan famously signed into law the Katie Beckett waiver as a response to this advocacy. And you can see him pictured there with Katie Beckett. But again, this was an imperfect patch. So something that they didn't think about, that wasn't an issue at the time, that has become an issue, is that a lot of these kids now live into adulthood. So at the time when this was signed in the 80s, most of these kids didn't make it to adulthood, but now they do, including Katie Beckett. And so once they turn 18, they need to leave their homes and go move to a residential facility. So again, we're moving forward with the best of intentions, and there's a lot of fantastic advocacy happening to try to expand coverage for individual people, but doing the system in this patchwork way is inefficient and leaves a lot of holes. So I'm going to talk too about specifically Medicare and what's going on with Medicare Advantage, because I conceptualize this as one of the patches in our system right now. So traditional Medicare, like I mentioned, you're automatically enrolled when you're 65. It covers the vast majority of doctors and treatments, but patients are on the hook for 20% of co-pays for outpatient care with no cap and around $1,600 deductibles for hospitalizations. It doesn't include any vision or dental care or hearing, and unless you sign up for Medicare Part D, it doesn't include medicines either. So most patients who are on Medicare, traditional Medicare, also sign up for a Medigap plan. Medigap is supposed to eliminate co-pays, and it's sometimes unaffordable for people. Normally the premium is $159 a month is the average, and Medigap, the problem with it is that you only have 6 months to sign up for it after qualifying for traditional Medicare to get a policy without underwriting. So that means that after those 6 months, you can have it counted against you if you have pre-existing conditions, which by the time you're 65, basically everybody does. And it can also affect your coverage. So Medicare Advantage is becoming a more and more relevant alternative. The idea behind Medicare Advantage is that private companies will take the money that the government estimates it would have spent on the average person on Medicare coverage, and it gives that to the private company, and then the private insurance company insures the patient, and they often attract patients with some perks, they'll include vision and dental, and sometimes they'll offer coupons for groceries or gift cards to get the patients on the plan. And theoretically, Medicare Advantage is supposed to provide the same coverage that traditional Medicare covers, but like I'll talk about in a few minutes, there have been a few studies that have demonstrated that that's probably not what's actually happening. And the difficulty is that people who choose Medicare Advantage only have 12 months to qualify for a Medigap plan without underwriting. So what happens is a lot of patients choose Medicare Advantage, and again, for Medicare Advantage, I don't think I mentioned, the premiums are often like totally free or they're very cheap. And so a lot of people who maybe are worried about the cost of the Medigap plan will choose Medicare Advantage. And then once they run into issues with coverage, which is often more than 12 months from when they originally signed up, they are unable to switch back because they're unable to get a Medigap plan without underwriting. And this seems to disproportionately happen to like low-income people. There have also been accusations that Medicare is selecting for people who are healthier as a way to try to, Medicare Advantage is selecting for those people as a way for the private companies to make more money. Like they'll do things like put their offices on like the second floor, but there's no elevator, or they'll offer like a free like gym membership, knowing that that's maybe something that will attract more active people. There have been studies looking at that also. So when we poll people, people who are on Medicare Advantage versus traditional Medicare seem to be like about comparably pleased with their plan. And when we ask specifically about like difficulty accessing care and like coverage and perceived cost of care, things seem a little bit worse for the Medicare Advantage people, but not significantly worse. But when we look at more objective data, that's where we start to see the differences. So this graph is looking at the differences between 76,000 patients who are Medicare eligible and either on traditional Medicare or on Medicare Advantage, and how far they had to travel for cancer treatment. And it looks like, hey, like the traditional Medicare people had to travel further. But that's because traditional Medicare patients who are diagnosed with these cancers are more likely to get care at a recognized cancer center, like a tertiary center with more experience doing surgeries for these complicated cancers. So yes, the patients have to travel further, but they're more likely to go to hospitals with more experience to treat their conditions. And people with traditional Medicare are way less likely to have complications from these surgeries. And there's also less of a delay between diagnosis of the cancer and treatment, which again is likely related to coverage issues. So it does seem like there are issues, there are differences in the coverage offered by Medicare Advantage and traditional Medicare. And then when we look at the rates at which people report having medical debt, which is slightly more objective than like how they feel about cost, we also see that people with Medicare Advantage report higher levels of debt. So those are the Band-Aid solutions. We also have a lot of people who are left entirely uncovered by these Band-Aid solutions, uninsured people, and we still spend a lot of money on uninsured people. So there's $40 billion spent per year on care for uninsured people. That's different. That doesn't include what the uninsured people are spending on their own health care. Most of that is government spending. Around 80% of that is government spending. 20% of that is like physicians providing charity care or cost shifting, where premiums might go up for other people to cover the cost of caring for uninsured people, and I'll talk about that too, or like GoFundMe pages, things like that, or like that extra 20%. So these are a couple things that the federal government does to cover the cost of care for uninsured people right now. So one of the things is that CMS pays hospitals at a little bit of a higher rate for their patients with Medicaid if those hospitals also see a lot of patients who are uninsured. So in that way, they're kind of indirectly through the patients on Medicaid covering for patients who are uninsured. Additionally, hospitals that are nonprofit and they're not paying federal taxes are supposed to offer charity care. However, there have been a couple studies that show that hospitals are under offering the charity care. It's often something that's not made well known to patients, and it's difficult to do. It requires a lot of paperwork, and the rules change depending on the state and depending on the hospital, like exactly what qualifies for charity care. This study on the left was a report on like how much charity care that people are supposed to be getting, actually not getting, that turns into bad medical debt, and they calculated it at about $14 billion. And then on the right, I put a map of where HRSA, the Health Resources and Services Administration, sends grants. So HRSA does a couple things to try to help cover care for uninsured people. One of those things is they have a program called the National Health Service Corps, of which, in full disclosure, I'm a beneficiary, where they will pay back student loans for providers who choose to work in settings where they're taking care of a lot of people who are uninsured. They also offer grants for community health centers, like where I work, like Esperanza on the Southwest side. And like I'll talk about in a minute, those grants often aren't enough to keep the lights on, but it is something to help cover care for uninsured patients. So like I mentioned, the HRSA grants are usually not enough to actually keep things going at these community health centers. And the community health centers are important. They're a big part of how people get care in the United States. 1 in 12 people in the United States gets their primary care at a community health center like Esperanza. But most of these sites have to apply for multiple federal grants. So this is an excerpt from the book, We've Got You Covered, where they talk about it's not uncommon for community health centers to have to apply for dozens of grants in order to maintain operations. But these grants are largely federal grants. So all of this money is coming from the same pool of money, taxpayers, federal taxpayers, but sometimes these already under resourced clinics have to pay for departments to stay up to date with all of the paperwork and all the requirements to be compliant with like up to 50 different grants that they might have to use. And some of these grants are earmarked for different things, right? Like taking care of patients with HIV or taking care of Native Americans or training residents. But it's another example of how if we're not upfront with what our commitment is, and we've already made clear that we are committed to having these community health centers, right? HRSA is already spending money on it. Federal taxpayer money is already going to it. Like as a society, we've decided this is something we want to do, but by doing it really inefficiently on the back end with a very patchwork system, we're creating a lot of inefficiencies that require like loads of people with salaries to be doing all this paperwork all the time to try to keep these community health centers that are very important open. And then in full disclosure, this is a little bit of a controversial topic, whether or not cost shift actually happens. So what cost shift is it's the idea I alluded to earlier, where if a patient goes to the hospital and they're uninsured and they get a lot of care, the hospital, and they're unable to pay it back, the hospital doesn't just eat that cost. The idea is that the hospital distributes that cost among people who are able to pay their bills or who have insurance or like public insurance. And that the private insurers specifically are able to recognize that maybe people who live in areas with a lot of uninsured people, their costs are more expensive, and so those insurers might raise premiums for people living in that area because they perceive that, oh, if you live here, your healthcare costs are going to be more expensive. So the best data for this was out of 2005, which is old data at this point. It was like pre-ACA, and there's been data and like a lot of debate since then arguing about whether or not this exists, whether or not it happens. Even if it does happen, like as mentioned on the bottom left there, it would be like 1.5% of what we spend on premiums. So it's not like a huge thing, but it's another example of how it's possible that we're paying for the care for uninsured people indirectly. And all of this care adds up. So all of these patches and all of this caring for people who are uninsured adds up to the tune of us being ranked third. The United States is ranked third, according to the World Health Organization, in terms of per capita government spending on healthcare. This isn't per capita spending on healthcare, this is per capita government spending on healthcare. So we're rated, what, just below Monaco and Norway, and we're spending more out of taxpayer funds per person on healthcare than a lot of peer countries with better outcomes who have single payer systems, because we're spending the money really inefficiently. But we're already spending the money. All right. And so when people talk about how we compare to other healthcare systems, something they often mention is that our outcomes are a lot worse than other countries. So this is a graph of life expectancy in the United States. Obviously, this is confounded by, like, we have a bunch of corn subsidies, and so we have problems with obesity and chronic conditions that other places don't have. We also have guns. There's more inequality here compared to peer countries. So this is a little confounded for purposes of my argument. In terms of healthcare outcomes, in the United States, if you have a heart attack or a stroke and you go to the emergency room for that and you get care, your outcomes are comparable to people in other countries. So if you have an acute emergency, our outcomes are pretty good. Where we see the big difference is in management of chronic conditions. So people are way more likely in this country to be admitted with conditions that could have been managed as an outpatient or could have been prevented. So those are things like diabetes, congestive heart failure, asthma attacks. This is where our system really shows its weaknesses. People in the United States are way more likely to endorse having skipped preventive visits due to concerns about cost. And so take-home points from part one of the talk is that our current system is a product of short-sighted patches put on a system that's not really working. It's really inefficient. So this type of system results in us being third in per capita government spending on healthcare, but and on top of that, we're also spending everything we're spending on private healthcare, and we're paying more than countries that already have a single payer system that is more streamlined are paying. And our system fails to provide coverage and leaves huge holes. So something that I haven't really focused on in this talk to this point, I don't think, is that when I make offhanded references to these people are uninsured and they're not able to pay their bills, and so the rest of us have to chip in and pay the bills. Those people, their lives are often ruined by that. They're bankrupt. It can be a life-changing amount of money to be billed, and people are unable to access sometimes even life-saving care, and so that does have a huge human impact. And because of the way our system is set up, our incentives often don't align with what our goals as a society are. They don't actually align with patient care. We're not prioritizing preventive care, and we pay for that foregone preventive care when we have to pay more for people who let their diseases get worse to the point where they need hospitalizations because they're unable to afford preventive care. And it kind of reminds me of this house. I think it's called the Weston House, something like that. It's a big, beautiful house in California that was built by the widow of a gun magnate in the 1800s. But the way that she built it was she would build a couple rooms, then she decided she didn't like one of them, so she'd knock it down and she'd build another one. And it resulted in a bunch of this ginormous house with a lot of stairways that went nowhere. And if you wanted to get from point A to point B, it was super circuitous, it was amazing there. And I feel that's what our healthcare system is like. We have a lot of stairways and doorways that don't go anywhere, and it's really difficult to get from point A to point B. And it doesn't have to be that way. So that takes me to point 2, which is where do we go from here? So I'm going to outline my 3 favorite arguments for single payer. There are many, many arguments for single payer, but these are my 3 favorites I'm going to highlight. So the first one is universal coverage. So people don't go bankrupt when they get sick, and they're not as worried about coverage. So it's easier for people to switch jobs, or if they're unemployed or they get sick and they can't work, they're not as worried about losing their coverage. Or if they decide they want to stop working to take care of their children or a sick relative, or they want to start their own business. These are things that people would be able to do because they wouldn't have this fear of going bankrupt if they get sick hanging over them. So in the United States, we have a lot of people with medical debt. So 8% of adults endorse having medical debt. And the Consumer Protections Bureau endorses it's the number one reason why people have debt sent to collections. It's the number one reason why people declare bankruptcy. So this is a huge problem in this country. And when we think about why we have a health system in the first place, there are countries that are less organized with fewer resources, where the system is you show up, and if you have resources to pay, you get treatment, and if you don't have resources to pay, you don't get treatment. But we have the benefit of more organization, and the idea behind having a program at all in the first place, behind having any type of coverage, is so that people don't go bankrupt. But our system is clearly not doing that, and it's not giving access to people. The second argument is it's a better method of cost control. So the estimate is that 1/3 of spending on health insurance, on healthcare in this country, goes to waste. I'm going to argue that a lot of that is due to the current system, where we have a lot of employer-sponsored healthcare and a lot of people are left uninsured. So one of the reasons why a single-payer system would result in better methods of cost control is that there's less insurance overhead and less health spending diverted to profit. So I think I showed a slide from him earlier. I should have mentioned, but this is Dr. Ed Weisbert. He is a speaker on physicians who works with Physicians for National Health Program, and he sent me his slides to use in my talk. But so he's fantastic, and he was one of the people on the first slide. If you want to look him up and read about his thinking, I encourage you to do so. But yeah, so this is one of his slides about what percentage of premiums goes to overhead and profits. So you can see for private insurance companies, it's more, it's 13 to 18%. For Medicare Advantage, which is not included on this graph, it's 15%. Traditional Medicare, by comparison, is 2%. So there's a lot less overhead and a lot less money that's just going into individual business people's pockets. And that is money that we are spending on healthcare, but we're not getting anything back from it. We're not giving that money to people who are innovating. We're not giving it to people who are cleaning the hospital rooms. We're not giving it to people who are laying hands on patients in any capacity. This is just going to people who studied finance and are moving things around a spreadsheet. So there's less billing costs associated with single payer. So in the wake of the killing of the United Healthcare CEO, there was a lot of media attention paid to like, why do we have insurance in the first place? And an argument that I kept hearing, so I heard it in this article in Vox, and then I heard it on this podcast, and then I heard it in the Tribune, this Michael Millinson article, was that we need to have insurance, and I'm sure you have probably heard this argument too, we need to have insurance because they need to argue prices down, because otherwise doctors are just gonna spend ridiculous amounts of money on like ordering MRIs for like tension headaches or whatever. I can tell you that if it sounds ridiculous to you all to order MRIs for tension headaches after like 10 years of medical training, it sounds extra ridiculous to order MRIs for tension headaches. So that's honestly not where the majority of denials and prior authorizations come from. In my experience, they largely come from people who have need medically indicated care, and the insurance company is dragging their feet because they have a profit motive to do that, because they're beholden to their fiduciary responsibility to their shareholders, and so they're trying to always be increasing their profits, and so they'll deny care or make it more difficult for physicians or other providers to fill out prior authorizations or jump through the hoops to get care covered and reimbursed. And in contrast, in the United Kingdom, they have an organization literally called NICE. It's a government organization, and their job is to evaluate different forms of treatment and decide whether or not the National Health Service is going to pay for them. And if it's worth it to society, they decide they will pay for them. And if they decide it's not worth it to society, they won't pay for them. Yeah, so that's one way in which single payer can do the same thing, but more effectively. Another thing I actually wanted to mention is that when we have a complicated system of a variety of payers, even if one payer says like, oh, I'm not going to like pay for anesthesia for an appendectomy beyond like 40 minutes or whatever, that's just one payer. And so even if they were effectively negotiating prices down, it doesn't have a big impact on the system. Whereas if you had a single payer who was able to effectively negotiate, prices down, it'd be much more effective. Because in the current system, there's thousands of different individual plans that people are on. And if one plan makes one weird rule, it's not really going to change practice patterns. And even if it did, everybody else would still be getting care the other way. So the current system also creates a lot of waste in terms of billing. So for example, the University of Toronto Hospital has about 1,200 beds and 7 billing clerks. And the Duke Medical Center has about 900 beds and 1,600 billing clerks, almost 2 billing clerks per bed. So that's, again, a lot of waste that we have to deal with now, because our system has resulted in paying for healthcare being a war between two corporate entities, between hospitals and large healthcare systems paying asking for payment for services that are provided by providers and nurses, and insurance companies that are taking money from patients and taxpayers. And so they're going to war with each other all the time, every day, and it's really an arms race. Whoever has the most staff to fight with each other is able to save more of their money, and it results in a huge amount of waste that we wouldn't have to deal with under a single payer system. And then also, like I alluded to, under a single payer system, there would be better negotiating and less cost shifting. So I think a really, really good example of this is prescription drug prices. So everybody knows that in the United States, we pay a lot more for prescription drugs than people do in other countries. And a large reason why that's the case is that our fragmented system means that we're not able to negotiate prices down. So for example, in the United Kingdom, if a drug manufacturer wants to sell to the market there, they have to take the price more or less that the NHS is offering. And if they won't take that price, then they can't sell in that market. So they have an incentive to sell at a lower price. In the United States, we don't have anything like that. And so our prices are totally bonkers. And an argument that I often hear as to why we need these high pharmaceutical prices is that if we don't have high prices, the pharmaceutical companies will have no incentive to innovate. But people have done research on this, and it seems like actually most novel drugs are coming out of really small startups that are spun out of academic projects that are taxpayer funded. And big pharmaceutical companies are much more likely to spend their money renewing or like slightly altering existing medicine so that they can maintain their patents, because they know that that's like a surefire way for them to earn more money. And they're also creating drugs for diseases that already have a lot of treatments. So as a primary care doctor working in a setting with not a lot of resources, this is something that I have to be very attuned to, because it's a very, very common pharmaceutical company maneuver to release a medicine that maybe there's a study that it's slightly better than what exists. Oftentimes that difference isn't even like clinically relevant in the studies, but they'll advertise it a whole lot to patients, and they'll charge multiples of the price of the second best thing. And it'll be all the rage in like the podcasts that doctors listen to, and in the journals, and at the conferences, and at the academic centers. Like everybody will be on these medicines. But as someone who has to keep in mind that a lot of my patients don't have insurance and pay out of pocket or use government programs that aren't going to cover the latest and greatest, like probably not worth it thing, I have to keep that in mind. And I see it all the time. And if we had like a single payer who was able to take control over what medicines are actually worth it to a society, that would also be a lot of money saved. So the Congressional Budget Office in 2021 released a report analyzing what they felt the economic impact would be of single payer. They estimated it would be between increasing national health expenditures $0.3 trillion and saving $0.7 trillion, depending on the variation of single payer that was implemented by 2030, and they released that in 2021. That was their estimate. And some of the fantastic thinkers that I put on my first slide wrote a response letter in Health Affairs where they outlined some of the ways in which the CBO report might have actually underestimated the cost savings associated with single payer. Specifically, it didn't take into account that the government would be saving money on what the government spends on employee-sponsored health insurance for all of the government's employees was one of the things. So my point is, even the Congressional Budget Office estimates that this could be like budget neutral or even save us money, even with some of the things that they might not have been taking into account. And then the last argument that I have in favor of single payer is that it's a better allocation of resources to prioritize patient care. One example of that is global budgeting for hospitals. So this is something that is talked about in the Congressional Budget Office report, but implementing single payer would give us the opportunity to transition away from a fee-for-service model to another model. It doesn't have to include that, but I think it's something that could happen this way, and I think it'd be really, really difficult to implement it on a large scale without a move to single payer. But the idea is that in the current system, fee-for-service means that when you go to the doctor or you go to a hospital, you pay for every individual thing they do to you. So if they do more imaging or if they do more surgeries, you're paying per unit imaging, per surgery, like per procedure done. And global budgeting is kind of analogous to a capitated system, which means that a payer would give a health system or a doctor, a hospital, a set amount of money, what they estimate it would cost to take care of you. And if the doctor or the health system spends less than that amount, they're able to keep the extra amount that they save as profit. And the idea is this would flip around the incentives and minimize healthcare waste, because we'd be less likely to do like maybe not necessary surgeries or not necessary imaging or things like that. But another benefit of a system like this would be that it would support a lot of critical access hospitals, especially in rural America. A lot of those hospitals are in crisis and closing because under a fee-for-service model, they don't have the volume to keep the doors open. But under a single-payer system that was able to implement global budgeting or a capitated system, the government could pay these hospitals to stay open, and it would improve access for a lot of America. And then also it would allow us to finally prioritize primary care and prevention. So in 1982, there was a big Supreme Court decision. It was Arizona versus the Maricopa Council of Physicians. And the Supreme Court decided that physician organizations are not allowed to negotiate with insurers to try to bring their fees up. And that ultimately spelled the end for privately owned, like independent physician practices, which really impacted primary care and drove salaries down for a lot of them and left them with no other option besides joining large health systems in order to negotiate with insurers, because that's the only way that primary care doctors or any doctor can negotiate with insurers now is through working at a large health system, which has resulted in many more physicians being employed, which has a couple of impacts. One, it really deprioritizes primary care because under a fee-for-service model, these large institutions they encourage their primary care doctors to make a lot of referrals for a lot of things that the primary care doctors can probably do, right? So see your gynecologist for your pap smear, see your cardiologist to manage your hypertension, see an endocrinologist to manage your like type 2 diabetes. These are all things that in my clinic I do all the time, and we're definitely trained to do them. And it's honestly pretty wasteful to waste the specialist's time when we have a shortage of specialists taking care of things that are really mild that could be managed by a primary care physician. But the system is incentivized to do that. The health system is incentivized to do that because they make more money if the patient has 5 doctor's appointments when it could have been 1 doctor's appointment. And this also impacts the quality of care. So like everything, like coffee or like clothing, like when things corporatize and when the people making the decisions are not actually dealing with the people receiving the product, the quality tends to go down. And we see that specifically with what's happening with private equity buying out hospitals and health systems. So there was an instance recently that was pretty well publicized on the East Coast for a system of hospitals called Steward Healthcare, and the private equity firm that bought the hospital just completely gutted it. There were not like supplies in the hospital to take care of people. Everything was really, really understaffed. They sold the ground that the hospital was on, so the hospital then was obligated to pay rent to whoever they sold the ground to. And then the people that did this, they all left and they gave themselves ginormous bonuses. And there's been a lot of legal fallout, but this is something that happens. And there have been studies that show that hospitals that are run by private equity, the patients have worse outcomes, which is really not a surprise to anybody who's encountered this on the ground. The idea is that a lot of these forces have decreased primary care salaries, and they made it a less attractive option for graduating medical students. So it is true we have shortages in all specialties. We need more doctors, but the shortage is much more dramatic when you look at primary care. So this is the AAMC projected shortfall by 2036. They estimate between 20,000 and 40,000 primary care doctors we're going to fall short. And for specialists, we're between a surplus of 3,700 and a deficit of 5,500. So you can see it. We really need primary care doctors, but we don't just need medical students to choose to go into primary care. We need people who are trained in primary care to actually do primary care. So this is the difference. Again, on the left, I have the expected shortfall for primary care physicians, and on the right, I have people who are trained in primary care, like internal medicine or family medicine, who choose to go and work in a hospital. So there's a projected between like a 1,300 doctor shortfall and a surplus of 4,900. So we really need people to choose to go into primary care, but it's really not attractive right now because you're often working for these ginormous profit-driven systems that don't prioritize you, make you work really, really fast, and don't let you practice the full breadth of your training. And your salaries are depressed because you're no longer able to, it's no longer a viable option for you to like go leave and do your own practice. This has a big impact on the healthcare system. So primary care has been associated with extending life expectancy, even when controlling for the number of specialists in your area and controlling for socioeconomic factors. If you have more access to primary care, you're going to live longer. Like I mentioned before, a lot of the driver behind why we have poor health outcomes in this country compared to other countries is because we're not managing things on the front end. We're waiting until conditions get really sick, or till patients get really sick, and then we're deciding to manage them, which is not only is worse for the patient, but it's really, really cost inefficient. And so the idea is if we're able to have one single payer and an intelligently designed system that is not just a series of patchworks, we can maybe actually prioritize taking care of patients and doing that with more prevention instead of waiting until people get really sick. So I'm going to end the talk with talking about future directions a little bit. So Howard Zinn is one of my favorite thinkers, and I'll get to him in a second. But two of the books that I mentioned on the first slide, they are weirdly optimistic about future directions for healthcare, and I'm fully aware they might have just been doing that to try to sell books. But the arguments that they make are, one, that we should, instead of taking it that all other healthcare systems have figured this out, all of our peer nations have figured this out, and we, for some reason, are like irreparably broken, and we're never going to figure it out, and we should be embarrassed about that. Instead of focusing on that, which might be true, but instead of focusing on that, we should think of it as everybody else has figured this out. They have conquered the vested interests in their economies that didn't want government-sponsored insurance, that were making money off of private insurance or things like that. And they overcame all that, and they eventually arrived at a single-payer system. And so it's maybe one of those, like if everyone else in the room has flu, maybe you're going to get it too. Maybe we'll get there. Maybe that just is the way that the arc of history bends on this particular issue. And the second argument is that employer-sponsored insurance is just getting worse and worse and worse. It's getting more and more expensive. It's harder and harder for employers to offer it. And coverage is getting worse and worse. And reimbursements to providers are getting worse and worse, which again affects quality of care. And on the other hand, when the government does step in and when the government does try to regulate private insurance or when they offer coverage, it's really hard for them to roll that back because those plans are really popular and they're really effective, right? It'd be extremely unpopular to like roll back Medicare and get rid of Medicare. It would be really difficult to get rid of like the protections for people with pre-existing conditions. And so maybe as we make progress, that progress is more protected and we're watching employer-sponsored healthcare get weaker and weaker, and maybe it'll collapse, and that'll be an opportunity to do something different. And Howard Zinn, if you haven't read this book, I highly, highly recommend it. It's not explicitly about healthcare, but it's about American history in general. And one of his theses is that looking at history, it looks like a long story of people abusing each other and taking advantage of each other. But there are some moments where people are able to come together and they're able to make a difference, and we should try to focus on those moments and try to learn from those moments. And I think that maybe this is one of those moments. So that's a summary of my presentation. Thank you for your time.
Very nice, a lot of information for y'all. We are going to get to question and answer in a few minutes. Before we do that, we are going to take a brief interlude and ask you to help contribute to the Ethical Humanist Society of Chicago. There's lots of ways you can do that. You can become a member, you can join, you can volunteer. It is a volunteer organization. We are now, though, going to ask you, if you can, to contribute some money. We have baskets, we have QR codes, you can do it online. We also accept Zelle. You can find that on our webpage. And so a brief interlude of music, and then we'll be right back with questions. Going to move to question and answer. If you're online, please post your questions there, and they will be messaged to me, and I will voice your question here at the microphone, which is off to my left. Anyone in the room, if you want to ask a question, just line up over there and ask the questions. Please ask questions and make them succinct to allow everyone an opportunity to ask their questions. Please.
First of all, Doctor, thank you for your commitment and passion. And I know you have to speak quickly to get everything in. The quick question historically is, in fighting for single payer, which I think a lot of us agree with, is the way to do it. In other words, where is the cooperative function that we can most readily and most accurately get single payer to happen. So that's the question really. What do you see as the best methods for bringing single payer, not only in Illinois, but for the example like California, one state single payer, or the sense of doing something that we can individually do? Where are the cooperative functions that you see where we should start?
Yeah, thank you so much. That's a really fantastic question. So I think there's a Milton Friedman quote about economists where he's like, our job is to like keep the good ideas alive until they become politically feasible. And I honestly feel like that's not just economists. I feel like that's all of us. So, you know, it's true that if you're not in a position of power in DC, it's difficult to imagine you having like a big impact on whether or not something like single payer happens, because it's such a ginormous undertaking. But I do think a lot of what's necessary is organizing so that we're ready when the political moment comes. There is an organization in Illinois called the Illinois Single Payer Coalition, and I encourage people who are really passionate about this issue to reach out to them. They do a lot of organizing, like reaching out to policymakers, like letter writing campaigns. They meet with policymakers. They encourage policymakers to like sign on to letters and legislation that is in line with moving more towards single payer and less like further away from an employer-sponsored system. And those things do help. They totally do make a difference. But I do feel like the moment is going to come, and I feel like being organized for when the moment comes so that we're able to make our voices heard exactly when they're needed is maybe the most important. So reaching out and being connected, I think, is important, and learning about the issue so you can talk about it when needed.
Thank you so much for giving us so much information, and there were like 3 slides that caught my attention. One said that the insurance industry profit and overhead were one of the least contributors to inefficiency. Mm-hmm. Then there was the one about the anesthesiologist, which looked like they were gaming the system. Mm-hmm. And then the Supreme Court decision and its impact on physician corporatization. Mm-hmm. Could you just talk a little bit more about all 3, and particularly what the Supreme Court was getting itself into? Yeah,
of course, definitely. So I think the first one would have been this one. So it is true that profits that insurance companies take in are not the largest part of the waste. They're not like the biggest reason why our costs are so high in this country. Costs are so high in this country due to inability to negotiate prices down and due to waste spent on like hiring a whole bunch of billers and a really like bloated system and not prioritizing primary care. And so we have a lot of sicker people. So we do waste money on health insurance executive bonuses and stuff like that. I'm not a fan of those things, but those aren't like the main reason why health care is so expensive in this country compared to peer countries. And then let me see, it was this one. So this is an excerpt from this article, but I disagreed with this article. In fact, I submitted a response, but I had never heard back. So yes, this article does say that their interpretation is that anesthesia providers are overbilling and they're giving patients like anesthesia longer than necessary, and insurance companies are great because they're going to fight back against that and prevent anesthesiologists from doing that. But the Professional Society of Anesthesiologists wrote a really robust response to this. I'm not an anesthesiologist, but I read the response. I can like quickly summarize what I remember as like the key points, but they cited some other evidence that like that's not what's happening at all. They're not overbilling, and also having been in an operating room and like doing surgeries during like my training, that also doesn't totally make sense. Like anesthesiologists are not the hospital stands to make the most money when they're doing surgery in the operating room, and so hospitals really try to optimize the time in the operating room. It wouldn't make any sense for them to be sitting in the operating room with the patient under anesthesia if a surgery is not happening. They're also like there's always a team counting the minutes in the operating room to make sure that turnaround time is minimized, again, to maximize the hospital's profits and to minimize risk to the patients. And minute by minute, things are documented. So it'd be really difficult for there to be like a widespread conspiracy of anesthesiologists keeping people under unnecessarily because there's many people in the room, everything is really well documented, and that's also just not how hospital systems make money. So I don't think that's really happening. And the author states, well, because part of the insurance company decision that was the impetus for writing this article was that they were not going to pay for whatever the anesthesiologist said, however long the anesthesia took. They were going to just pay what they felt the anesthesia should have taken for an average surgery of whatever it was. But the difficulty is sometimes there are complications in surgery that are unanticipated, and so anesthesia takes longer. And the author's take was, well, if that happens, it would be really easy for the anesthesiologist to submit a request for that to be covered. And so if there was really a problem, they could just ask for the payment and they would totally get it. But anybody who has worked in healthcare or knows anybody who works in healthcare knows that that's not how it works. It's really, really arduous and uncompensated to ask insurance companies to cover things that they've already denied. So that's far from a perfect system. And let me see, the other one was about the Supreme Court decision, Arizona versus Maricopa. So this was a decision in like the 1980s, it was 1982, where physician professional organizations were negotiating prices with insurance companies to advocate for higher fees. And they were doing that to represent smaller, independently owned physician practices, which used to exist everywhere, right? Like my dad was born in the 40s and tells stories about like the doctor came to his house with a black bag. That doesn't exist anymore, but it used to. And part of the way that those physicians were able to exist under a system where everything is paid for through insurance companies is they were able to get together and negotiate prices with the insurance companies. But when they lost the ability to do that, private independently owned physician practices went away. I think there's somebody maybe locked outside. Could somebody get the door? Thank you, sorry. But yeah, so small independently owned physician practices went away when this happened and physicians became more and more employed by larger healthcare systems. Yeah, any other questions about that? Yes. Yeah, so they said it was under the Sherman Act, they said it was price fixing. Yeah, but but when hospitals do it, it's okay. So, yeah.
I am curious because I always have thought of Blue Cross Blue Shield as the gold standard for health insurance. And I know the story about how they were started as a not-for-profit in the 30s. Mm-hmm. And I think officially Blue Cross Blue Shield is still a not-for-profit, but I've also learned, and tell me if this is correct, that they really exist as a group that licenses the Blue Cross Blue Shield name to a lot of for-profit companies, like a lot of just big health insurance companies. So I just am curious, like, am I even remotely correct about that?
That's fair. Honestly, I'm not totally sure. I know that they do license to many plans. Like there's many plans that are under the umbrella of Blue Cross Blue Shield. But if they're technically a nonprofit, that would be news to me. I haven't heard that. I mean, they certainly take in lots of profits. Like it's been. Let me see. Here we go. No, I think it's frozen. But yeah, on that slide where I was showing like the percentage of premiums that go to like overhead into profits, like they're on there. So they are taking in profits. They're not operating like what we think of as a nonprofit, but I mean, so are a lot of hospitals that say they're nonprofit. So, yeah, it's totally possible. Okay. Yeah. Thank you.
Good morning. Thank you, Dr. Doe, for all of that wonderful information and detailed information. I had two questions. One might not be 100% fair, but one of in your presentation, you point out that there's a lot of inefficiency, a lot of waste, et cetera, in Medicare. But our inefficiency and waste is clearly like the contributing to the profits of these insurance companies. And so there are these interests that are on the others, are benefiting from this system. And I think one of the challenges to us is to try to change the system. All of the other comparable nations that have single payer, have there been any examples of companies or countries that, Freudian slip, countries that have had to change their healthcare systems? And of course, there's probably like a lot of inertia that they have to overcome. So are there any examples of that we could use here in the United States as we like try to change our system?
Yeah, so that's a fantastic question. There definitely are examples. I am not as familiar with all the details of all the different battles that have gone on in all the different countries, but I know specifically off the top of my head, there was a lot of resistance in the United Kingdom with implementing the National Health Service. It was really contentious. I think it was like just after World War II or around World War II, but they overcame it. So I'm sure there are good models. Off the top of my head, I don't know details, but if you're especially interested in that, I know the United Kingdom. And,
Okay.
yeah.
Oh, and it sounds like, to be fair, it sounds like you start the very first question was about that, like how to organize to combat that. The other question, oh, sorry. The other question I had was about, it sounds like one of the other large contributors to the cost of our healthcare here is like medications, pharmaceuticals. What some of the things that we can do to try to bring those costs down, for example?
Yeah, I mean, as individuals, I don't know if there's much that we can do at this point, besides like what I mentioned about trying to organize for single payer. The idea behind single payer bringing the cost down would be it'd be easier for them to negotiate a lower price. There is space for more regulation, and we could support like those startups that I mentioned. So I put a slide up showing like a graph of how much innovation happens at different institutions that with different companies that innovate pharmaceuticals, and the big corporations, for the money they make, actually innovate a whole lot less, and a lot of the best innovation comes from really small startups that originated in academia and were taxpayer funded. So supporting things like that would also help, yeah, and maybe I like reforming patents too, but that's getting a little bit outside of my scope. But
Yeah, there's actually a ProPublica article this month about the $2 million per dose price tag of genetic medication.
yeah, exactly, yeah.
So I have a question from our online audience. The question is, I'm surprised by how many physicians are not supportive of a single payer system, probably because of perceived loss of money and autonomy. Is this a real concern?
Yeah, that's a really, really great question. So the CBO budget estimate actually estimated that compensation would go up for physicians, especially primary care, but across the board. So I'm not concerned about it. Yeah, but it's definitely something that I've heard people express.
I wanted to know if single payer was an all or nothing option. Like, is there a way to transition from our current state and have private payer in the future alongside single payer? Like, for example, to lower the age that you qualify for Medicare?
Yeah, it's a really good question, and I think that is probably more feasible. There has been a lot of discussion about like what would be like steps in the right direction. So public option is something that's been floated a lot, where there would be a government insurance plan that people could choose to buy into, or they could choose to stay with their employer-sponsored insurance. Something that Dr. Troy Brennan, who wrote The Transformation of American Health Insurance, one of the other books I put up at the beginning, one of his thoughts is that maybe there will be like an option that employers could choose to buy into instead of a private option, as employer insurance gets less and less attractive. And yeah, so there's definitely opportunities. There was an interesting think piece recently by Matt Iglesias, who interviewed like Bernie Sanders staffers, and Sanders obviously campaigned on Medicare for all, but his question for them was, if Sanders made it into office, like what would he actually do? Because he realistically couldn't have immediately passed Medicare for all through Congress. And so they were outlining different like steps in the right direction, policies that he could have implemented. So yeah, I think there's a lot of space to improve the system. And to move towards that. And like I mentioned too, like as we make steps in that direction, they're popular and they work, and people like them, and they tend to stay around. So I don't think it's like a waste of time. Like, I don't think you need an all or nothing approach. I think that even people who are advocates, like practically, they're going to need to think about steps in the right direction to move towards something bigger. But I do think most of the benefits, the reason why you get them is because it's like one payer, like negotiating drug prices down. And it's like one payer that makes it simpler, so you save the most on billing. So you do get most of the benefits when it's simpler and bigger. But there's definitely things we can do in the meantime.
Hi. There's also a lot that's been talked about price transparency and surprise bills and things like this. So that would be something you could talk about. But I just want to ask about one little picayune thing that's always bothered me.
Yeah.
This is after 3 decades of self-employment. Okay, we can talk about the difficulties there, and now Medicare. But either way, when you get a bill, there's a price that shows up that the insurance has approved and how much the insurance is going to pay and your portion. But before that, there's what I'll call the opening bid price, which has no relationship to anything. It's 10 times what is ever going to be allowed. So I guess my question is, one, does anybody ever have to pay that? And number two, why does it even exist?
Yeah. Yeah. I mean, it happens, like, that's what happens when you don't check anybody with a profit motive, right? They charge like ridiculous amounts. They just keep adding zeros because there's no reason not to. Yeah, but usually, like, people don't have to pay that. People who are uninsured, they're billed a lower rate than people who are insured. The hospitals do that so that they can negotiate down with the insurance company. So, like, very, very, very rarely would someone actually end up paying like that crazy number. And yes, price transparency is something that can help. It's definitely would be a step in the right direction because it would allow patients to, with their eyes open, choose between different hospitals or different providers for their care. It's just really, really difficult to implement because it hasn't existed and there's a lot of resistance to it, but also healthcare is really unpredictable. Even patients who are really well insured, or they go to clinics that are supposed to offer like free care or whatever. Like at my clinic, we see a lot of people for really reduced rates or for free. You go to the doctor and you think it's going to be free, or you think you're just going to have to pay your copay. And even if that's totally the case and no one's trying to fleece you, you can show up and maybe there's a suspicious mole that needs biopsying, and so that adds on cost. And if they find something else that's like complicated and they need to talk about it, maybe that's an extra cost, and you're no longer just paying like the copay you thought for like a wellness visit. That does impact the ability to implement effective price transparency, but that's definitely something that would be a step in the right direction. And it would force hospitals to compete a little bit instead of just coming up with these ridiculous numbers.
So basically, this opening bid price has no reason to exist.
Not really. I mean, like, capitalism is why it exists, yeah.
Thank you for your presentation. Recently, I went to my rheumatologist, and he referred me to a hyper specialist. But my healthcare provider wanted me to go to one of 2 physician's assistants. Now, PAs are entering the healthcare industry, and I was wondering, is it to further depress primary care physician salaries, or is it to attract more people into the industry, or a combination of both?
Yeah, that's a fantastic question. I think it really depends who you ask. I think both things can kind of be a little bit true. I think that from a health systems perspective, they're primarily profit motivated, and they're going to hire people who they feel like can do the same work, but they'll have to pay them less because that's an easy business decision. But it also is true, like I put on the board, like we do have physician shortages, and so they are expanding access. When mid-levels go into practice, they're expanding access, and that is not a bad thing. Yeah, so I think both things are true depending who you ask. I do think we just have to be careful with like using them purely for profit. I think it's kind of a new thing, and I imagine that more regulations are forthcoming. Yeah.
Okay, thank you very much. Much appreciated. We're going to make some society announcements before we wrap up. Our next virtual community chat will be on Wednesday, February 26th at 7 p.m. We share friendship, issues of the day, and fun in a caring Zoom chat. Join us to connect and enjoy others' company. You can find the link in today's bulletin or in the activities page on our website. Vitalent, one of the nation's largest nonprofit blood and biotherapies healthcare organizations, will again be taking blood donations at our building on Sunday, March 9th between 10 and 3 p.m. If you are interested in donating, use the link in today's bulletin to schedule an appointment or contact Dan Kaplan with any questions. Our humanist kids are sponsoring a community care drive to collect some essential toiletries and baby supplies to benefit the clients of the Niles Township Food Pantry. You can find a list of donations that we'll be accepting at the donations table in the reception area or in today's bulletin. You can send a financial contribution at the link in today's bulletin. We'll do the shopping for you. The deadline is March 16th. See Allie Cook with any questions. On February 23rd, next week, the topic of our Community Day discussion will be creating and supporting community. What communities are we each part of, and how do we support them? We will think about the various communities we're each part of as individuals, families, employees, etc. Consider what is meant to be part of that community. How do we support these communities in ways beyond our time and dollars? Essentially, we'll be exploring what good citizenship looks like in different contexts and reflect on whether and how our good citizens in our various communities. EHS member Katie Merrill will lead the discussion. On Sunday, March 2nd, in 2 weeks, children's book author Sarah Schachter will present the magic of writing for children. On her website, Sarah shares that there is nothing more joyful than writing for kids. Children's literature is steeped in kindness, insight, silliness, empathy, wonder, and hope. It's a great gift and profound responsibility to write for the best audience ever. In her presentation, Schachter will talk about her career as a children's book author, the collaboration between an author and illustrator, the research required for kids' nonfiction, and many other aspects of children's publishing. Our humanist kids will join us at the beginning of the program when Sarah will read a story and share some of her behind-the-scenes secrets of storytelling with the kids and adults alike. She'll have copies of her books on hand. For more details on upcoming Sunday event programs and other activities, see our website, ethicalhumanistsociety.org. Connect with us on Facebook and Instagram, and subscribe to our YouTube channel for videos of past speakers and future streaming programs. And to close today's event, before we please join us for coffee hour, I'm going to read a quote from that occurred here in Chicago in 1966. At the Medical Committee meeting for Human Rights, Martin Luther King was present and said, "Of all the forms of inequality, injustice in healthcare is the most shocking and inhumane." Thank you.